regards to reimbursement, the CDC held a conference over the summer to look at reimbursement, and just about all commercial insurers agreed to pay it. And the reason for that was that they felt two things. Number one, it was cost effective for them to prevent HIV by doing this, so they didn't have an issue with it. Two, they didn't see the cost driving their other costs relative to heart disease and diabetes and all the other things that large commercial insurance companies deal with. They didn't think this was that big a deal. And it would also be an FDA indication. So they did not have an issue with it. Government payers such as Medicaid, Medicare, I haven't heard anything that Medicaid, it depends who provides medicines for those various payers. In DC, we have various Medicaid payers that utilize some of their HIV meds through ADAP. Since ADAP requires HIV positivity, it's not worked in the district to do that very well. Interestingly enough, if you have Medicare, it's covered, but not Medicaid. So some of this is going to be community by community, city by city, where those issues will play out. But commercial insurers, for the most part, have weighed in, yes, they'll cover it. Okay, so we're open to questions.
You have a comment. You.
In looking at the studies and seeing that people are, that you want to get these people on PrEP, have you taken into consideration people who come in and is on PrEP, and you have other people out in the community who's afraid to come in and get on PrEP, and then they take their medication, and plus they sell it to other people in the community that's not willing to come into the healthcare facility.
So the issue about, so we see diversion already. So the question is, how much diversion is there of medication? Well, I mean, let's start off with something. PrEP is not going to address issues that are already widespread through the healthcare system. So people are already diverting medications. People who get a steady diet of HIV medications for treating their HIV are already selling it to people for use in clubs. So we know that you can go into clubs and you can buy recreational drugs and Truvada in a packet. And people are already doing that. And that exists well before PrEP even got investigated, let alone approved. So what can I tell you about that? The bottom line is there will be a social stigmatization for people who take the drug when other people realize they take it. Individuals are going to have to weigh the pluses and minuses of that before they decide to do it. The question of diversion will exist in either way, both for those who are negative who are taking it and for those who are positive. This won't address that. Did I miss a part of your question? No. Okay. And right, 1 second. Rodney, you were asking a question in the back?
I just wanted to clarify that I kind of heard conflicting whether it was lifelong or there were regimens, meaning that you could be on it for 5 years, 2 years, versus it was a lifetime. I just was curious to speak to that.
I think I don't think that the duration of treatment has been documented. I think that it's thought that people would take this. I don't think it's anticipated that people would take this their whole lives. I think it's more that people would take it at appropriate times of risk, periods of risk, meaning like months or years, rather than decades or a lot of years. But I think that is still to be determined. I don't think that the indication of the medication doesn't comment on the duration of time one would use it for.
And I just want to add that I think, again, it's a lot like the analogy to oral contraceptives. I mean, I think women take oral contraceptives at those periods in their lives where, I guess it's a little different from PrEP, where they're actually probably more in a committed relationship, but then they may stop, and then they may restart it again. And so I envision that PrEP use would be something like that. So, you know, when you're in that high-risk period, that's when you would use it. But as Rick said, the clinical trials ended after 2 years. So a lot of these open label implementation and demonstration projects are going to have to look at the long-term effect.
So my question.
Oh, who's Sure.
So my question to what you just said is that if you take clinical and study, what about resistance?
What about what?
I mean, what about resistance?
So the issue of stopping and starting the development of resistance. So the drug will last probably in the bloodstream an additional 3 to 5 days after you discontinue use. At what level it get down? So the question is, if someone becomes HIV positive during that period of time that they stopped it or have a new exposure, would you be at risk for that? And we don't have any data on that. I think it's important to, in a clinical study, the data on resistance didn't demonstrate it. Now, that was data from clinical trials. The patients who entered clinical trials, you could argue, are not like the patients who will do this in real life. They're not as easy to organize. On the other hand, the study in IPREX showed that 50% of the people who were in the study did not adhere to the medications. I don't think that's so different than our experience in real life. So I'm not sure that the clinical trial population is so different. And I think that the fear of resistance is easy to understand. I, as a clinician, of course I'm afraid of that. But under no circumstances do any of the analyses that compare the risk of resistance in those people who take this medication versus using the worst percentages of efficacy and how much resistance would be prevented because you prevent people from getting HIV positive. The resistance equation always falls on the better side of taking PrEP.
She had a question. Do you still have a question, Ms.?
Yes. My question is this. As a cardiovascular specialist and working with HIV clients with other health disparities, I want to know, in your research, what are your exclusions? Heart disease, kidneys, DAOs, you know, people who are...
The exclusions in these, well, sort of anybody with creatinine below, yeah, the question was that she works a lot in the cardiovascular area, and she wanted to know what exclusions were present in the study that would exclude people with certain risks that related to heart or kidney disease. Did I summarize your question okay? And so patients who had markers of kidney function that would show they would have impaired kidney function, so they had GFRs less than, I believe, 70, were excluded from the study. And there was no exclusion for patients with evidence of heart disease. It was really a kidney disease or a low marker of kidney function was the main way that people were excluded.
I listen about the opinions of the infectious disease specialists, but if I'm not HIV positive, I am not going to visit an infectious disease specialist. I'm going to visit my primary care physician. Then do we have the opinions of the primary care physician about the PrEP?
No, that was, maybe it didn't come across clearly, but that was my point, that we're looking at a biased sample of people here. And so other cities, I think in the South, there's been some studies looking at what primary care physicians think about PrEP. And so I think that would be the logical next step here in DC, is to figure out, you know, among the non-HIV focused infectious disease providers, what would the primary care doctors, would they be comfortable prescribing PrEP? Would they have the capacity? First of all, how much do they know, if anything?
About HIV, about PrEP, are we willing to prescribe it? What are the problems? And the other thing is, probably patients will be also good if we have Latino patients in these studies. Then we can see what happened with the Latino patient, because we have a significant number of Latino patients.
Well, IPREX was predominantly done in South America. So this would be the first study that we've ever seen that the predominant evidence is drawn from
Well, I'm talking
Latin
more
America.
about the opinion of the non-HIV people, to see what do they think Latinos who are non-HIV about taking PrEP, if they have a sexual partner.
You're talking about Latino providers or Latino patients.
Latino patients who are not HIV. positive.
Well, IPREX addresses that, I think. IPREX, which was predominantly, it was South American and Central American, so it's not all, depending what you mean by
the focus groups that you did were in African
two different groups.
Right.
Two different groups. We're talking about two different data sets.
Right.
One data set that looked at the clinical trial was predominantly in Spanish-speaking people. That study showed a high buy-in rate. But I think your question, which is important, raised the issue about what kind of providers are going to do this. And we have no data on that. There's another study that looked at providers in the Los Angeles area, 190 physicians. Of the 190 physicians, the definition wasn't based on infectious disease, but those who cared for at least 20 HIV patients. So it included a lot of internal medicine and family doctors. I'm a family doctor. So it looked at those groups, and in that you saw very similar results to what Amanda showed. It's unclear to me that primary care is going to be the first group of physicians who do this. I would say they won't be, because it's not going to be people who are unfamiliar with these medications. And I think this is going to be a challenge, because HIV negative patients are going to have more access to primary care providers, and primary care providers haven't used these medicines, so they're going to be reluctant to use them. So this is going to be a relative barrier when we get started.
I think we saw similarly with routine HIV testing. I don't know if that's what you were going to say,
No.
Lisa. But again, this notion of, CDC is recommending everyone should get tested for HIV annually whenever they go to a healthcare setting, and we have seen little interest and little uptake among primary care providers and generalists who don't necessarily deal with an HIV-infected population.
Dr. Caldera, you're raising an excellent point about the primary care providers. I was on an advisory panel with Gilead a couple of months ago about this very issue. They don't know what the answer is, but if you look at their marketing strategy, well, they're not planning to market PrEP, but they do anticipate that primary care providers might be using PrEP, so they're actually looking for input. And so I grabbed the mic just because I wanted to let you know, and if there's anybody else who wants your voice heard, I would actually write to Gilead about your concerns about the primary care providers, because they actually don't know the answers to the questions that you're posing.
And also, I believe, I don't know, I've been trying to get to the exact numbers, maybe you know, Dr. Elion, but the numbers of people in IPREX who were actually African Americans, I think, was very low.
Oh, it was like
It couldn't be more than what?
it was less than 80.
Less than 80 out of
3,000.
So I think there's also concern I've heard raised that we don't really know how PrEP is going to work in the African American population.
I didn't have a question. I just had a thought. Something you said about testing is I envision PrEP having the same difficulty we have with people that get tested. I work for a community-based organization. People that come in to get tested are people that are pretty sure of their HIV status. They are not at risk. Well, it's not that they're not at risk. They don't have really high-risk behaviors. And so, I'm concerned that people who are going to be willing to take PrEP are people who don't have really high-risk behaviors, and just reaching people who would probably benefit, and you said it, people who may benefit the most may not necessarily be appropriate. But I think even getting them in to ask them about PrEP is, that's the challenge.
I think there's going to be pretty clear. So we're rolling out a protocol at the clinic right now to help develop who's going to get PrEP, and we're only going to give it to people who are considered high risk. People who come in who want it, who aren't high risk, we're not going to offer it. So that's the way we're going to deal with that, and that we're going to have people who agree to do it sign a consent, that they understand what the explanation was, then there'll be a written document acknowledging. It's not even just us. When Gilead produced materials that the FDA required them to do, they were required to produce a document that both patient and provider will sign, attesting to what they understand the regimen to do. The real question is, how will we create an environment that people at risk feel comfortable coming into healthcare centers? And like, we don't have data on this, so I'll only speak from my experience. Rather, I'll give you an example of a program. So in Vancouver, they have a program where they supervise injecting drug users. So it's a program where people come in and they bring their heroin or their cocaine, and sometimes they bring needles, sometimes they don't, and a nurse will supervise them and give them a clean needle and clean syringes so that they can inject their medication. If the patient doesn't know where in the arm to inject it, the nurse will show them where to inject it, and then the patient will inject the medication in their own arm. That sounds crazy, right? So they did that in Vancouver, and when they did it 5 years ago, the biggest group to oppose that was the Chamber of Commerce and the police. 5 years after the program, when they went to do the renewal, the biggest supporters of the program were the Chamber of Commerce and the police. The program demonstrated a 85% increase in substance abuse treatment programs. It showed a reduced rate of HIV amongst IV drug users from 14% to less than 1%. Because what they did is they decriminalized and gave you a place to deal with your behavior. The hope, and this is only a hope, we have no data, that will create an environment, and we're trying to figure out tools that we can use to assess that when we help people realize that we're going to offer something that will decrease the risk of their having sex, that will create an environment that process of engagement and having to come in repeatedly will lead to more responsible behaviors. There's no great technology how you make irresponsible people act responsibly. Nobody has a way to do that I'm aware of, other than, have somebody huge following them every second of the day and give them millions of dollars to act better. That's not practical. So we're hoping that by creating a more nurturing, supportive environment for people who operate on the fringes, they'll come in. I can only tell you that when I have a patient who I told this story to, he's in a group that communicates through a listserv group, a computer internet group, that they have 30 to 60 guys who get together every Wednesday, and they have unsafe sexual practices in the afternoon. And when he heard that we would have such a modality, he said, I can get all 60 to come in. And we'll see if they come. But the point is, there's all kinds of activities that people are doing that we don't think are right. I have a patient who tells me about a group that meets in near DuPont, not near DuPont Surplus, like in Tenleytown, in Tenley, Northwest DC, where they get 40 to 60 guys who come in at lunchtime for 2 hours, about 80% of whom are married, and they come in and they have sex parties. And they do that every day of the week. And everybody knows that, and he's telling me the stories, and I'm trying to act calm, and my mouth is like wide open. I said, you're kidding me. But the point is, if we wouldn't see this number of incidents that we're seeing, 5,000 new cases, and it's not just in Tenleytown, obviously, this is happening in every ward. But if we don't take we've got to take an attitude that we can't tell people what their behavior should be. It just is, it's not that we don't want to, because I try and tell my kids what to do. But as a doctor, it just doesn't work. They don't listen to me. So the idea is, how do we create an environment that will promote engagement? And then once we create that environment, who's going to be the best person for PrEP is going to be between individual providers and patients. In the back.
Perhaps taking a cue.
Is this more or less?
I'm taking a stand down. Perhaps we can take a cue from prescription marijuana model, if you will. And it goes back to social work precepts also. You got to unconditionally accept people for who they are or what they represent. No judgment, all right? Perhaps we can use that as a way to really co-opt bad behaving people, to turn their lives around or something.
I think
cooperate.
My mind, in that regard, I'm with you there, Mark. And I believe that story that I told you about what happens in Vancouver, which was replicated, by the way, at another clinic in England, is very representative of that. That program to decriminalize and encourage safe, illegal drug use in a medically supervised setting would never make it in the district. Okay? There's no way that's happening. And yet the scientific evidence to support that approach is stone cold solid. okay? There can be no, I mean, the data is pristine, but it's never going to happen because we live in a mixture of science and culture. It's a hope, and yet, and I say it merely a hope, because we don't have data, to know that by making a less judgmental attitude towards a behavior that historically, since man was born, go back to Adam and Eve in the Bible, has always had an area of judgment. And HIV is still a sexually transmitted disease. IV drug use is not the predominant way it's done. It's a sexually transmitted disease. So in some ways, PrEP is going to help engage people around that whole issue around sexuality. It's a new chapter.
But isn't the district considering legalizing medical marijuana use at this time?
I'm not even getting started. It has been legalized. Where the district is in deciding when the dispensaries, which have already been selected, open up. But that is not what we're talking about today. And the lady who's been patient.
How many days of continuous use is required for efficacy?
The question is, how many days of continued use is required for efficacy? And the answer is the treatment has been approved for daily use. You're asking an off-label question. And the off-label answer to your question is, we don't know. There is data to suggest that from pharmacologic studies that if people will use it 4 times a week, it might be good enough for 7 days of protection. But there's currently a study that's evaluating that, and that's only from modeling data, not from real clinical data. So the recommendation and the dose that we'll use in the implementation is daily use. In the back in the white.
Yeah, my question is, isn't that similar to the model that you were speaking about earlier on methadone? It knocks down the criminality, but it does very little else. And this knocks down the risky sexual practices, but it does little or anything else. It doesn't address other needs.
It's what makes giving talks interesting. I think that's a matter of opinion. I understand, I respect your point of view. I see it as a little different. To me, methadone is, how many of you work or have worked in methadone programs? Okay, of the people, keep your hands up. Of the people who work in methadone programs, how many like the effects of methadone? There we go. You don't, okay. So my experience is that methadone is, my experience with methadone, having worked in a methadone clinic for a year, I quit. Because I couldn't stand what I was doing to people. I couldn't stand watching people fall asleep in front of me. To me, it was an unacceptable medical treatment. I don't see this as the same. I don't see this as having the same toxicity that methadone did. Methadone to me is a social formula for a societal problem, but not at all a medical solution. Suboxone, on the other hand, is a much more applicable drug.
Well, it seems like when you talk about a behavior, you're talking about an addiction. You're talking about a risky behavior. When a person takes this wonder drug, they feel that they're invincible by your own admission, right? Isn't that just as addictive? Maybe not as harmful in the long run, but
That's
just
fair.
as addictive.
That's fair. Yeah, I see your point. That's fair.
Well, what is it?
You can argue that needling is just as dangerous as unsafe sexual practices. So these are both ways to control that behavior. That's a fair analogy. In the back?
Is the PrEP treatment going to be coupled with psychotherapy?
Freely.
Is what was the question?
The question is, will PrEP be coupled to psychotherapy? And my answer is, if it is, there won't be much PrEP given out. The resources in a group of social workers, how much resources is there for increased demands on the mental health system in the district? So if we link that, it's not going to take off. Is there a need to do that? Yes, of course there's a need, because these are people who, by definition, are coming in because they're doing things they've been told not to do. So this is a group that's at high risk. But do we have resources to deal with that? No. Is there counseling that will offer them in terms of their behaviors? Yes. Is it adequate if they have mental health disorders? No.
Yeah.
Earlier you talked about Mississippi and women being pregnant, having access to PrEP or HIV.
No, they didn't have access to PrEP. Just
HIV treatment.
Yes.
Why is it only for the women for Mississippi?
No, they said Mississippi. policy.
Because people are moving to DC from different
Their
places,
law.
and people from DC are moving to different cities, and why isn't the same treatment given to other localities, other cities, other places?
I won't spend too much time on this, because a couple of years ago, I was doing a CME project, and it was just before the election, and I ended up getting a letter to my chairman of medicine not to make political comments. So I'm going to try not to make a political comment, and I'm going to try and answer your question. The benefits of Medicaid are still determined in many states by block grants to the states. And so the state adjudicates how they want to spend those dollars and who to spend those dollars on. And Mississippi decides to do it that way, and the district decides to do it this way.
But it's just like ADAP. I mean, ADAP is decided by each state, the eligibility criteria, and so you're going to see that variability across the country.
And you can be sure there'll be states, that will provide this potentially for Medicaid patients and other states that will not. That would be, there is a alternate view of this, which is that these things Medicaid would be a federal issue, and that the formula would be a federal issue. And whether that's going to play itself out is to be seen. Yeah.
Comment, observation. I'm a social worker in the addiction substance use field. Okay. Supposed to benefit from this information to serve my population. What I've seen here is not so much pertinent from all your research and everything, and we are there except for the adherence as far as I see. So I would have wished you had some people in the population you worked with, but we are there willing to support, because that's what we do to ensure that they take their medication.
Yeah, I mean, we had a very small number of people who were self-reported, had a history or were current injection drug users. There are other clinical trials that are focusing on PrEP among commercial sex workers. Injection drug users is one of those populations. The results are not yet out or available. But when they do come out, I can see, I'm not sure that, I'm a pediatrician in training, so I'm not sure I'll be prescribing much PrEP, but I'm not sure for the adult clinics, or the adolescent clinics for that matter, if, again, we're talking about you really trying to identify anybody who's at high risk for HIV. And so if you have an injection drug user, and again, there are mixed feelings about whether or not they actually may be more adherent to taking some of these medications than other people, then I would think that that would be someone you would consider giving it to, as long as there are no medical contraindications and that kind of thing.
One of the reasons the Danya Institute wanted to have this program, particularly for people working in addictions and substance abuse communities, is because you all are on the front lines. And we know that in a lot of these programs, routine HIV screening is not happening. And Dr. Elion talked a lot in the beginning of his talk about how critical it is. It's vital for us to get people tested. So if you're looking for things that you can do, we wanted you to have the information and give you access to the experts. But I think what you can do is take these messages back and say, we have to help find the high-risk individuals who might be able to be channeled into these programs when we get them set up.
Let me comment on that. I can't underscore Lisa's remarks enough. I think one of the real benefits of PrEP is that now we have something to recommend testing for those who are negative. In the past, we've had things to recommend for those who are positive, to get you on treatment, to do all that. But now for people who find out they're negative and to find out there's something they could do proactively rather than just do their whatever their behavioral thing, I think is a real incentive to get tested. There is no greater prevention tool than getting tested in Washington, D.C. PrEP pales in comparison. If you all can convince 100 people to get tested today, you're more likely to find 1 or 2 people who are HIV positive. That's going to prevent a lot more than we're going to do in PrEP in the next week. So if there's one thing you take away from what we said today, it's convince 2 people to get tested. Gentleman in the back, and then you. All right.
One thing that I'm not sure if you are saying PrEP is, if you are comparing PrEP with TASP, that's treatment as prevention, is it cost effective? Which one is better, treating the patient or the program of PrEP?
So the question.
If PrEP is better, if you are saying that
No,
it's better.
that's easy to answer.
No, I have a follow-up question. If we are saying PrEP is better,
It's not.
Yeah.
with the economic slowdown worldwide and having majority of the HIV patients worldwide are getting their medications for free with the fund obtained from donation, and with the politics of cutting spending and worldwide, how does the implementation of PrEP impact it?
So there's two questions that he asked. The first is between treatment as prevention, meaning for HIV positive people who are untreated, to get them treatment first so they don't transmit HIV to others, versus the protection of becoming HIV positive for a negative person. Overwhelmingly, it's more cost effective to prevent transmission from a positive person to a negative than to prevent a negative person to become positive. That's the first point. So, no debate on that. The second question is the cost effectiveness. You know, depending on cost effectiveness involves making calculations, and depending on the way you what cost you give to each assumption, you can drive any cost benefit calculation any which way you want. There are the best ones that I've seen look based on prevalence, so based on numbers of cases, because then you can tell how efficacious the regimen will be. What cost you attribute to the cost of not preventing depends on your area. I'm going to Uganda on Monday, okay, and I'm going to be there next week teaching. And the cost of a patient in Uganda, if they get in the hospital, is not the same as the cost of a patient in a hospital in Washington, D.C. However, the cost relative to Uganda of a patient being in the hospital can be very similar to the relative cost in the United States, because it might be $100 versus $1, but no different than $10 versus $1,000 here. So the point I'm making is that I think these determinations really are based, the best ways I've seen it have been based on prevalence. And there's a point below which the prevalence, when there's enough HIV, when HIV is so uncommon in a community, that pre-exposure prophylaxis is not cost effective. And there's a place that where it's up to a certain point, and I believe that number, and I'm not positive. Do you remember from those calculations? The one that looked at the cost benefit in different prevalence settings, where you'd see the cut point. I can't say the number, but my recollection, and don't hold me to this, was around 1%. So in a city like Washington, where it's 3%, it's cost effective to do pre-exposure prophylaxis. In other parts of the United States where it's less than 1%, or if that's the number, because I don't remember well enough, it won't be cost effective. But that's an arithmetic calculation, and there's places it makes sense and places it doesn't make sense. Yeah, hold on one thing. On the other hand, routine testing almost always makes sense, regardless of unless the prevalence is so low. So routine testing makes sense in most prevalent settings. Sorry.
I'm just trying to make sense of the cost effectiveness in my mind. The 3% that you mentioned, those are people that are receiving regular treatment?
No. The 3% prevalence means of people living in Washington, D.C., 3% of the overall population are HIV positive.
Right. Are those people receiving treatment?
I showed a slide that showed of the 1,000 people, in this case, there's how many in the district?
14,000, about 14,500 people living with HIV.
And we know of the 14,000 or so, probably about a third of them are successfully controlling their virus. Right now, Amanda's leading a project that's going to help us know the exact numbers. But based on modeling, it looks like about 30 or 40% of that 14,000 is successfully controlling their virus. Does that answer your question?
Yes, so I don't see how the 3% is still relevant to the 1% if it's only 30% of the people that in the 3% that are HIV positive in DC are getting treatment.
Because 2/3 of the people are still transmitting virus. So since 2/3 of the people are still transmitting virus, or 2% of the population, it would be cost effective. Because 2% means that 1 out of every 50 sexual contacts is going to be potentially risky. Those aren't, and there are certain populations of age groups among MSM where that number goes up to 1 in 5.
I was going to say 1 in 50.
Yeah, the 1 in 50 of the population, but that includes 95 to 0.
Yeah,
So when
African American MSM between the ages of 18 to 29 is like what?
20%. So if you're in that population, your risk is 1 in 5. So there's definitely, I mean, I hope you're not coming away from the message that I'm saying PrEP is for everybody. PrEP is not for everybody. I'm not here as trying to spread that we should be prescribing drugs to everybody who's HIV negative. That's not what I'm saying. What I'm trying to say is that we now have a new tool to add to our other tools. We need to figure out in what settings how to use that tool and how to use it wisely. And it's not for everybody. But in the area where there's high prevalence, it's more interesting to me than an area where there's not a lot of HIV.
Okay, you have a guy that's on PrEP, or either a patient who's on PrEP who is non-adherent, and plus he converts. How many regimens have he been knocked out of once he have converted?
So the question is, if you're a non-adherent patient on PrEP and you convert, what's the risk of resistance? Well, IPREX really looked at this, and what they showed is that if you're a non-adherent patient, what's the thing that we know most likely you're not doing? Taking your meds.
Correct.
And if you convert, it's pretty evident you're not taking your meds. So people who convert while not taking their meds have low risks of developing resistance because they weren't taking their meds.
Because they weren't taking.
Because they're not taking the meds. When the virus is growing, there's not a lot of the drug around.
Right.
So the rate of resistance in that setting, contrary to what our fears would be, is very low. Because the people who convert are the people who don't take their pills.
I understand that, but I'm on high blood pressure medicine. I don't take my high blood pressure medicine as prescribed.
You should.
And I'm a nurse. And I know I should. And I'm a nurse. I forget some days. I feel better some days. I don't have a headache some days. And so I skip a dose, maybe 2 or 3 doses. Same thing about people that take HIV meds.
No, there's a difference.
Are they 100% compliant all the time?
No, but there's a difference. There's a difference. The people who take their HIV meds intermittently, it doesn't accumulate in the blood. And if they don't accumulate in the blood, there's not a sufficient amount of drug when virus is growing to develop resistance.
So who develops resistance?
Resistance are people who take most of their medicine.
They take.
You see, if you take none of your medicine, you're cool. If you take all your medicine, you're cool. But if you take almost all your medicine but not all, you're screwed. So the people who get B's for taking their medicine, you know how you were in school and you always objected to the people who always got B's? You were in that group that got C's and you're just nervous they were a little smarter than you? Well, they're getting their comeuppance here. So those people, if you take most of your meds but not all, you're going to have enough drug that is going to stay present, but that's enough to potentially allow a person to be infected. When they looked in the data from the studies I showed you, the people who got infected don't have detectable drug in their blood.
But how many regimens have they been knocked out of once they do convert?
There's not enough resistance that was developed that I can answer that with data.
Are you asking if someone, in the event someone develops resistance?
Yeah.
Oh.
How many?
I understand.
How many?
I understand the question. This is a common question, which is everybody is very worried that by taking this medicine, they're going to develop resistance. It's one of the biggest things we saw in your survey. A third of the providers, I think, something like that, were worried about the risk of resistance. I'm telling you now, there will be people who develop resistance. There is no. I'm not saying that because the study showed there wasn't resistance. I think there won't be resistance. There will be resistance. In the studies, the number of patients who developed resistance between 5,000 patients, less than 2.
But he wants to know how that impacts your treatment
Of
options.
the two, it's arguable that it would have influenced it. They developed a particular mutation in M184V. That one, M184V, is a little bit of a bad thing, but not a really bad thing. And so it doesn't necessarily impact, for instance, you wouldn't necessarily take a regimen. There are currently 3 fixed-dose combination pills available. of the 3 fixed dose combination pills, you would be less likely to use 2 of those 3 pills, and maybe you'd be able to use the 3rd. But if you wanted to take 3 pills once a day, that for sure wouldn't be compromised. Data show that would be compromised. So the impact of that on subsequent choices, which is what you're really asking, I think is not so well understood or documented, because A, it's not a common phenomenon, and B, the mutation that you get is one that you can still succeed with a lot of regimens. I don't want to say it's not a cost. It's a cost. It's a bad thing to develop resistance. To develop this with mRNA-4V is not something good. It's a cost of doing this, and it's a negative. But we just don't know how often that negative is going to occur compared to how many. Let me just leave it at that. We just don't know how often it'll occur. It's puzzling, because you'd think that'd be a big problem, but there's this funny window between when you take enough drug that you develop resistance, but that you don't take enough drug that you get infected. And that number seems to be protecting people from getting resistance, because they're not taking enough drugs. So when you get virus in your system, it's not seeing drug, because there's not enough drug that's been taken. Now, if someone did take drugs for a week, got infected, and then took their drugs the next week, I'm sure they would develop resistance. But in the 5,000 people they looked at, that's not the way people are non-adherent. People who are non-adherent don't skip 1 week and take it the next week. They usually skip days.
So you're not.
What's that? In the white chair.
Since we're talking about prevention and prevention drug, is there a plan to look at the form that the drug comes in? I think you're saying it comes in like a gel tab or something. And just thinking about somebody who would need to take a pill day after day after day, is there some looking at an oral form or injectable form or something? A patch?
So there are definitely research studies ongoing to look at, as Dr. Elion mentioned already, this intermittent dosing, so that you wouldn't have to take it every day per se. There's the, I'm getting the exact term, on-demand PrEP, which is just, before you anticipate that you're going to have a sexual encounter, so you use it then. And then there are scientists that are looking at different methods of actually delivery. So for the Caprisa study that he mentioned, it was a gel that was inserted vaginally, but they're also looking at, for example, rings that might be able to have extended release. They're looking at, I think, subcutaneous or injectable dosing, right? Kind of like Depo. I'm trying to think of what else.
There's another drug that they could give once a week, a tablet that they're looking at. They're looking at all different approaches to look at this.
And they're also looking at other HIV medications. So they're looking at, as we mentioned, like they're looking at Maraviroc instead of Truvada to look at whether or not this approach can be used with other drugs, other antiretrovirals.
There's a ring that they're going to use, a different medicine that's not even formulated for oral. That would be like a cervical cap, but just a cervical ring that would be used. So we're just at the beginning of this technology. Question in the front there?
My question would be for the on-demand, for that option, I'm assuming that the dosage would be a lot higher than a daily regimen. Does that increase the side effects? Would that increase the side effects?
The question is, if you took it on demand, would you increase the dose? And if you increase the dose, would that change the side effects? So the on demand is not changing the dose. And it's not really on demand, it's before and after. And the question, and the data looks to me, that there's data to suggest that 4 times a week may be as good as 7. So my concerns about the on-demand is if you have sex once a week and using it as an on-demand, it's not going to be enough medicine. But if you think about it, for someone who's having 1 unsafe encounter a week, that wouldn't be someone you necessarily would be giving this medicine to. So you're thinking about people having more than a risky encounter per week. So I think that we're going to have to talk to patients about that, because I think if you take this medicine twice a week on an on-risk situation, there's no modeling data that would suggest it would work. And the medicine's not being used at higher dosages in any other study.
Now that said, the Caprisa study really was what we're talking about here, because it's a... It's a vaginal gel that the women, it was called the BAT method, so before and after. So the women, it was women in South Africa, oftentimes the partners were away during the week working, and so they actually could anticipate when they were gonna have sex, and so they would use the gel 12 hours before intercourse, and then they would administer a second dose afterwards. So in that situation, we did see efficacy. So I think it depends on how you're giving it and the modality.
They're not redefining high risk, are they? For PrEP?
What do you mean? The question was.
CDC
are we
redefining?
Yes, I mean, there's no redefinition of high risk behavior for PrEP.
No.
Well,
They use the same, they have guidelines for heterosexuals using PrEP and for MSM using PrEP, which are based on what they consider high risk.
Oh, okay.
But did you want to know where? The heterosexual guidelines came out in mid-August, I believe.
Oh, okay.
there was a big discussion. I didn't dwell on the heterosexual literature. I just showed the partners PrEP study, but there was a big debate in the heterosexual recommendations because of the 4 studies that showed benefit that looked at in heterosexual. One study showed no benefit for women, and when they did a further analysis of that study, it was really because the women weren't using the medicine in that particular study. So it wasn't so much a true evaluation of heterosexual risk as it was that particular study. And when you looked at the other 3 studies, you could show benefit in all 3 of the other studies in the low 60% range. So that led us to the understanding that it wasn't an issue about whether it was effective in women. It was just it wasn't effective in one study, but was effective in the other 3. When the FDA saw that and looked at the totality of the data, it changed the perspective about whether this was a remedy that was, as she keeps saying, remedy, a prevention strategy that was effective for MSM versus heterosexual, and they realized it was equally effective for both. Yes?
You may have already said this, but how quickly does it work? Like, what would you say to a patient as far as how many days or how long do they need to take it before it's effective?
The question is, how quickly can you expect to be protected once you start? And I say we don't know the answer to that. I'd say that we're recommending people be on it for at least a week before they start, but it sure looks that if you take 4 doses in a week, including at least 2 doses before, that might be effective. But I don't think we have an answer for that. There's no definite answer for that question. Over here?
I guess this segues into my next question, or into my question. There's no way to really assure that the reason why the person did not get HIV is that they had sex with partners who had undetectable viral loads. It was not actually due to the Truvada. Is there any way to?
Well, so the question is, how do you know that the lack of the lower infection rate in these studies was due to the drug, not just due to what kind of partners they had relations with? And the way you do that is by having enough people in the study and looking at the control arm versus the Truvada arm, that when you do a clinical trial design and you have such large numbers in both groups, you hope that that variable equals out in both groups. And so that's the assumption, and they do a power calculation to figure out how to look at some of those different factors in each of the groups, the placebo and the treatment group, and you have to have X number of patients big enough to eliminate the risk you just described. And in those studies, they felt like from the statistical design, they did eliminate that risk.
Yeah, I wasn't actually referring to the studies, but just in general population.
Well, you would never be able to know for any individual. But that's why we look at the study as a way to guide that, because you need some way that you can predict, and that's the best way I know to predict. It's not going to be the same for everybody.
You also have to, I mean, again, in those studies, people were not just getting PrEP, but they were also getting risk reduction in counseling, condoms, that kind of thing. And they measure intermittently. They had study visits and they would collect information about how often are you using condoms, that kind of thing. And again, people would get the same counseling in both arms. And then, as Dr. Elion mentioned, you want to make sure that people that are in your control arm are not different than those that are getting the medication. And you can really adjust for those other factors. So you can statistically make sure that you're not really looking at the effect of condom use, for example.
Let's talk about dispensation of this methadone.
Could you repeat that?
Dispensing provider. I mean,
What's the question?
medication in terms
cost.
of dispensation. Clients have to go over the counter, or they have to go to a provider.
The medication will be prescribed. The question is, what would be the route of dispensing? It's going to be prescribed as any other medication, over the counter. I mean, by going to see a pharmacist and getting the prescription filled. There was a big discussion during the presentation about whether this was the same kind of class as Accutane, that when a patient went to see a provider, they needed to carry documentation with them about their HIV status, the way a patient going to get Accutane has to carry documentation that they're not pregnant. So, and it was decided that that would be restrictive and block people utilizing it. So the patient, you can't get a prescription unless you're HIV negative, but you don't have to bring proof of your HIV status when you go to the pharmacy. In the way back, I think we'll take 2 more questions and then we'll be done. Yep.
Quickly, has it been discussed how much it actually costs? How much it costs monthly? I know earlier in the talk that people were like, from the study, they said, you know, I pay $20 a month. So, and I stepped out, so I wasn't sure if it was already out.
I don't know what the cost is, but it's way more than $20. Other questions? Thank you all. So I'll just say a quick thanks. I want to thank Lisa. I want to thank Lisa and the folks at the Institute for promoting this program. I think you guys were incredibly engaged for the last 3 hours, so we really appreciate everybody's questions.
Thank you. Thank you again. Another round of applause. Please do not leave until you